only 900 received a deceased donor transplant in Mexico last year. That means that there are 15,000 who were waiting who did not receive a transplant. And the same thing happens every year. And many people die on the waiting list while waiting for a transplant. There were about 2,000 people last year who received a transplant from a living donor. So again, I can emphasize that if people can find a living donor, they will have a better chance for getting transplanted. Why were there only 900 deceased donor transplants? Because there are still many people who don't want to be donors. And one thing that we can help spread through the community is a spirit of organ donation. So if somebody knows somebody who needs a kidney transplant, to come and offer their kidney if they would like to do that, but also to make sure that when they die, their organs are used for transplantation. That is still, across the entire world, that is still something that we struggle with. Many organs will not be used for transplantation, even though we could have saved lives from that potential. When we talk about a donor and a recipient, so just for my terminology, the donor is the person that's donating the organ, either living or deceased. The recipient is the person with kidney failure who is receiving the organ. As you heard from my colleague, and you saw from Anna, I don't know, Dr. Moreno, and as you heard from Anna, you saw the police, the immune system police surveilling in the recipient. So, right, so the recipient, our bodies want to deal with infection. Anything that's not us, our bodies will try to kill. That's why we don't die from infections. But when our body sees an organ from somebody else, they will also try to kill this organ. But we have ways to make that, to suppress that, using medications that we call immunosuppression. Some people call them anti-rejection medications, but I will refer to them as immunosuppression. We use immunosuppression because no matter who your donor is, there is some incompatibility. Unless your donor was a twin. If your donor is a twin, there is less issue, but that's very, very rare. So there is some incompatibility, and there are two sort of categories of incompatibility. There's what I call the hard incompatibility. If I cross this incompatibility, almost no matter what I do, the transplant is going to fail. And that's blood type and HLA. So HLA are the proteins that live on your cells that define who you are. Now, if you have antibodies to these proteins, and I do a transplant, that transplant will reject. How do you get antibodies? You get antibodies to a protein if you have seen this protein before. When would your body see a protein before? Well, maybe you had a previous transplant. This is your second transplant, and now you're seeing that protein again. You have antibodies, and you will mount a very, very aggressive immune response. If you have had a pregnancy, and that your child had that protein that you do not have, maybe your spouse's protein, then you will have an antibody. Or if you had a blood transfusion, and many people with kidney failure will have some blood transfusions, if you had a blood transfusion and you saw this protein, you will have antibodies. So we can test for these antibodies, and we can test for the blood type, and we can test for the antibodies and the blood type in the recipient, and we can test for the proteins, the HLA proteins, and the blood type in the donor, and we know if there is a hard incompatibility. If there is a hard incompatibility, we enter an area of transplantation that is quite complicated. Either we do kidney exchanges, so that we don't use your donor, we use somebody else's donor, and then we make the transplant happen that way, or we use a whole new area of medication called desensitization, where we eliminate your antibodies during the time of the transplant. It's quite complicated and somewhat risky, and so we try to avoid that. So those are the hard incompatibilities. The softer incompatibilities are, for example, if you are 20 years old and the donor who wants to donate to you is 70 years old. That's quite an old kidney you will be getting. Maybe you can enter an exchange and find a younger kidney or something like that. If you are a very large patient and your donor is a very small donor, then the size can be mismatched also, and sometimes we use kidney exchanges to help people find a size that's better for them. HLA mismatch is also a soft incompatibility. So you see that I've listed HLA as a hard incompatibility and a soft incompatibility, and I want to help you understand, because this is an area of quite a lot of confusion, sometimes even in the transplant community, but also in the general community. So remember, I told you, you have your HLA proteins. I have my HLA proteins. If they are different, which they will always be, then your body will be trying to attack my HLA. And that's why we use immunosuppression. If it's just a difference between HLA, immunosuppression can help reduce the risk of rejection, and finding donors where the difference between HLA is the smallest difference, where it's minimized, will give you the best outcomes. But if you've seen my HLA before from a blood transfusion, pregnancy, or a previous transplant, now you don't just have a mismatch. There isn't just a difference. You have an antibody. And if you have an antibody, we cannot cross that with just simple immunosuppression. So that's the distinction between HLA antibodies and HLA mismatch. We can go to the next slide. So why do we care if somebody is incompatible? What are the risks that occur when you are incompatible with your donor, either a hard incompatibility or a soft incompatibility? One of the risks is that of rejection. Rejection is when your immune system tries to attack the organ. Now, rejection does not mean you lose the organ, and we see this confusion also, even with our own patients. They think, oh, if I get a rejection, I will lose my transplant and I will be back on dialysis. We can treat rejection if we detect rejection early. We can give more immunosuppression to treat the rejection. For example, thymoglobulin that you heard about was sort of the original drug for treating rejection. You get rejection, you give this drug, the rejection is resolved. But we want to avoid rejection because we want to avoid the number of times we have to treat the rejection, and every time there is a rejection, there is a risk to the organ. The other risk of incompatibility is you need more immunosuppression. So if you have a donor who you are maybe slightly incompatible with, we can use less immunosuppression. If you have a donor where you are very incompatible, we have to use more immunosuppression. Every time we give more immunosuppression, there are risks of complications from the immunosuppression. There is no such thing as a free lunch, right? We give immunosuppression, there are risks with the immunosuppression. We do a transplant, there are risks with the transplant. Immunosuppression drugs have the risk of cardiovascular risk of cancer, risk of infection, things like that. Because if you are suppressing the immune system, then cancers can grow. If you are suppressing the immune system, then an infection can occur as well. When people get a transplant, they have many medications that they have to take every day. And this is every transplant patient. This is the reality of transplantation.